Can you hear us, UTEP? Yes. Good afternoon. My name is Eric Kraus. I'm an associate professor in the Division of Dermatology at the University of Texas Health Science Center in San Antonio. And today I will be talking about dermatological problems in the aging, and I will be specifically concentrating on skin cancer and its precursors. The purpose of today's lecture is to show you lots of clinical slides, hopefully to enable you to be able to recognize the precursors of skin cancer, actually recognize skin cancer itself, and hopefully a few words on how to manage these problems. I realized that this was in the old millennium back in 1999, but these statistics are fairly valid. Talking about skin cancer update 1999, half of all new cancers are skin cancer. So if you're talking about cancer in general, 1 out of every 2 will represent a skin cancer. On the slide it says about 1 million new cases each year. I think that's a gross underestimate. I think we may see that many just here at the VA in San Antonio. This is the breakdown of the most common cancers: basal cell carcinoma, squamous cell carcinoma, and melanoma. About 4 out of 5 will be basal cell carcinoma. 16% will be squamous cell carcinoma, and around 4% will be melanoma. There'll be approximately 1,200 deaths from the non-melanoma skin cancer, and there'll be a little over 7,000 deaths from melanoma. So although melanoma will only represent 4% of the skin cancers, it will account for a larger number of the deaths related to skin cancer. I'll start off by talking about the various forms of basal cell carcinoma. If you're familiar with skin cancer at all, especially basal cell, most of you will be familiar with the nodular form of skin cancer, basal cell particularly. But I want to show you some variations. These will sometimes get confused with other clinical diseases. So let's start off with nodular, and then we'll go through the rest of these forms. This is a classic example of nodular basal cell on the nose. It's a pearly papule characterized by these telangiectasias running across the top of the papule. This is probably around 5 or 6 millimeters in size. As this slowly grows over time, months to a few years, the center will have a tendency to break down, form a little crust and a small ulceration. Another example of a nodular basal cell, clearly you can see the telangiectasias running across the top. This is an 8 millimeter lesion. It still has not ulcerated, but at some point in time it will. I want to use this moment to also describe that when you see a basal cell carcinoma in the location on the upper lip close to the nose, this is a high-risk site. And by that I mean this is the tip of the iceberg. This cancer is much larger than it looks like underneath. And a larger version, a 1 centimeter lesion, same characteristics. Here you have a little depression in the off to the side, and it's in the lateral lower eyelid area. 3 classic nodular basal cell carcinomas. Another one on the ear, only this time, same characteristics. Now we're starting to see some crusting and some ulceration underneath the crust. Now switching gears a little bit, we're still talking about basal cell carcinoma, but this is a pigmented variation. I would dare say that many of you, as soon as I flashed up this slide, was thinking melanoma. And that's certainly a reasonable thing to be thinking about. But I want to introduce this concept that basal cell carcinoma can be pigmented, especially in darker skin races. So we have the same little pearly quality out to the edge, lots of pigment, little pearly area here. So this is all pigmented basal cell carcinoma. Another example on the lower eyelid, you have a nodular lesion, a central ulceration, and this pigment extending out to the side. Again, not to be confused with melanoma, although it's certainly reasonable to be thinking about it. Pearly border and a large crusted ulceration in the center in the medial canthus area. Here we have an example of what we're referring to as a cystic basal cell carcinoma. It just looks clear, sort of like a small cyst. You don't see this too commonly. This variation of basal cell carcinoma is referred to as morpheaform basal cell carcinoma. And the reason this thing is important is many times it gets diagnosed as an old scar, an old site of injury, and it's left to grow over time to the point where it becomes very large. Here we have a scar-like center, but that same little raised up papular border, pearly type papular border, so very characteristic of basal cell carcinoma. This lesion, when you go to excise it, will probably extend out about another 5 to 7 centimeters around this area. So this is going to be a large, very large area. Again, we have another depressed scar-like area. This looks like a site of an old injury, scar-like process. But this, in reality, is a scarring type process, a morpheaform basal cell carcinoma, much more dangerous than the other ones we've talked about so far. And finally, the last variation of basal cell carcinoma I'll be talking about is this area right here. It looks like a scaly dermatitis. Very frequently, this gets confused with maybe a form of psoriasis, nummular eczema, contact dermatitis, tinea corporis, and it looks like a chronic dermatitis that never seems to respond to your antifungal creams or your topical steroids. Whenever you get into a situation where good treatment is not working against the diagnosis that you have made, then there's a problem. Either the diagnosis is wrong or the treatment's not being applied. If you think that the treatment is being applied, then you have to think about what other things might be in the differential diagnosis and biopsy the lesion. Dermatitis, it's very difficult to see that there's a very little papular edge to this. This could easily be confused with the things I just gave in the differential diagnosis. Now here's one on the lower abdomen, pearly-like quality, a little bit of pigmentation. On closer examination, you can see this pearl-like quality in this pigment. This is a pigmented superficial basal cell carcinoma. So that basically reviews the various forms of basal cell carcinoma, except to say that what I want to now show you in the next 2 slides is what can happen if you neglect basal cell carcinomas. You may say, well, it takes a long time for them to enlarge. You don't really have to worry about it. Well, that's not entirely true. If you neglect them long enough, this is what can happen. You can get a huge ulceration, many centimeters in size. And you still have that pearly raised up area, but now you're starting to get into a major surgical problem. Total neglect for maybe 10 or 15 years. Here's an individual that I saw on some military duty while I was in Central America. You can notice that this is a dark-skinned individual. This was a Honduran woman that had allowed this thing to just go for many, many years, and essentially her eye is gone. So although basal cell carcinomas are not really known to metastasize or to create great damage, if you leave them long enough, they certainly can cause both. Here's an example of a basal cell that was treated. You can see the white scar-like background, and you can see the recurrences in the center. One way in which we treat basal cell carcinomas that are not too large is we use cryotherapy with liquid nitrogen. We've outlined the clinical lesion with this marking pencil, and then we froze 4 millimeters beyond that for a border. And when you use liquid nitrogen, you create an ulceration like this, and over a period of about a month, this will heal up with a white scar. Now later on, after I talk about squamous cell carcinomas, I'll come back and talk about the treatment of both basal cell and squamous cell carcinomas. So leaving basal cell carcinoma, let me now switch to squamous cell carcinomas, and starting off by talking about the precursors. The precursors, for practical purposes, are actinic keratosis, Bowen's or squamous cell carcinoma in situ, and arsenical keratosis I won't say much about, just to let you know it is a squamous cell carcinoma precursor. This is a fairly typical type skin seen at the VA hospital in San Antonio. Many of our veterans are fair-skinned individuals. They served in wars overseas in which they had lots of sun exposure that they couldn't prevent. Years ago, we didn't know about sun protection, and people were told to get out in the sun and get some tan or toughen up. Well, this is the end result of what happens when you have fair skin and you try to toughen up over the years in sunlight. You have numerous number of actinic keratosis characterized by these red, scaly, flat papules and plaques. All over the entire skin here is sun-damaged skin. Here we have the hyperkeratotic type of actinic keratosis on the back of the hands. At this point in time, to be honest with you, you can't really tell whether this is a hypertrophic actinic keratosis or an early squamous cell carcinoma. The lips can also be involved, and frequently are, in fair-skinned individuals where you have this chronic scaly process here on the lower lip. We call it actinic cheilitis, but it's actually actinic keratosis or premalignant lesion on the lips. The treatment of actinic keratosis are multiple ones. We frequently use liquid nitrogen. We also use a product called Effudex cream, which is a 5-fluorouracil compound. Let me also point out at this moment that any commercial products that I mention, I have no financial interest in any of them. You can do chemical peels, and they vary from glycolic acid peels to a thing called Jessner's peels. You can also use beta-hydroxy peels with salicylic acid as a mild peel. Photodynamic therapy, you put on a chemical, delta-amino levulinic acid, and you let that penetrate. You expose the skin to light, and that photoactivates the skin lesions. And you can also dermabrade the skin. So there are multiple ways to treat actinic keratosis. Here's an example of using 5-fluorouracil or Effudex cream. The patient applies it twice a day to the entire face, and they do that for at least 10 to 14 days, or as much as they can tolerate. You can see how inflammatory reaction, the kind of inflammatory reaction that you get, and you can see that there are very few areas of sparing. Wherever there's no reaction, there's no sun damage. So this individual has an entire face full of sun damage. Here's an example of application of a chemical peel, frosting that you get as once you apply the chemical, regardless of what you're using, you get this kind of a frosted appearance. and subsequently you'll get some desquamation of the skin. Moving on to what we call Bowen's disease or squamous cell carcinoma in situ. It looks a lot like the actinic keratosis, only there's a lot larger, more crusted areas here. So here you have one that's squamous cell carcinoma in situ. Here you have multiple actinic keratoses. Classical example of Bowen's disease. Again, let me point out that some of these conditions have a fairly large differential diagnosis. You might look at this plaque and wonder why I'm not calling it psoriasis or nummular eczema or some form of dermatitis. And a lot of times that's exactly what we do. We go ahead and give it a nonspecific diagnosis, treat it with a little topical steroid, and if it doesn't respond, we go ahead and biopsy it. A large plaque with lots of crusted ulcerations, a squamous cell carcinoma in situ. Certainly at this point, I can't tell you with all honesty that there's not a squamous cell carcinoma within this large plaque. Here's an example of a thing that we call keratoacanthoma. It's a nodule with central crust that grows rapidly. This is a lesion that will double in size within days to weeks. There's a real controversy of whether this lesion represents a benign type, what we call keratoacanthoma, or is this a malignancy, squamous cell carcinoma. So for practical purposes, whether you think this is a benign or malignant lesion, it's best to treat it as a squamous cell carcinoma because both clinically and histologically it's hard to separate. A typical squamous cell carcinoma on the back of the hand. I showed you something similar to this before, and I mentioned that this could also be a hypertrophic actinic keratosis. Sometimes it's hard to distinguish those two. They need to be biopsied and appropriately treated. A large ulceration right in front of the ear. This looks somewhat reminiscent of a basal cell carcinoma with ulcerations. Sometimes you can't always tell them apart. Clearly this is a skin cancer and it's large and in a bad location. Absolutely has to be surgically removed. A very large squamous cell carcinoma on the forehead, lots of sun-damaged skin in the background. Another one of those neglected lesions where the squamous cell carcinoma has become several centimeters in size with a large area of erythema around it on the central chest. Another area also on the trunk, more friable type nodule, again with a lot of surrounding erythema. I've seen lesions like this turn out to be basal cells, Merkel cell carcinomas, amelanotic melanoma. Absolutely has to be biopsied. A nodule on the helix of the ear with a lot of keratin material. This could be that keratoacanthoma I was talking about, but more likely to be a squamous cell, and as I already alluded to, you need to treat it as a squamous cell. Let me point out that there are certain areas on the skin, squamous cell carcinomas, when they occur in that area, they become much more dangerous. This is one of the locations. The helix of the ear, the lip, and squamous cell carcinomas evolving in scars are very dangerous lesions. They tend to metastasize, they tend to recur. And this is an example of a squamous cell carcinoma in the middle part of the lower lip. Extremely important that this lesion be treated and treated as soon as possible to avoid the possibility of this thing metastasizing. Large squamous cell carcinoma on the hand, misdiagnosed for many years as a variation of inflammatory processes. Squamous cell carcinoma, what are the factors? Certainly size, anything greater than 2 centimeters. The depth of the lesion when you're talking about 4 millimeters or so in depth or deep into the fat. when the histology is poorly differentiated. Sites I already went over: ear, lip, scar, recurrent tumors, those that are involving the nerve. And this is a very important piece of information right here: immunosuppression. If you're not seeing patients that are immunosuppressed, then you have a light clinic, because we're seeing people that are immunosuppressed every day. We see patients in clinic. These are our transplant patients, whether it be heart, lung, liver, kidney. These patients are at risk of developing malignancies of the skin. It would be a real shame if somebody survives their transplant and dies because they developed a metastatic squamous cell carcinoma. So what I'm trying to say to you is, you must follow patients, fair-skinned individuals. You have to follow their skin if they are on transplant medication. Okay, how do you treat non-melanoma skin cancer? Cryotherapy with liquid nitrogen is a choice. I showed you an example of that. We also use curettage and desiccation. After we go ahead and take a shave biopsy of the skin lesion itself, send that into pathology, we take a dermal curette, we curette out the cancer, and then we take an electrodesiccation needle and electrodesiccate the area and repeat that process 3 times. You can also use superficial radiation. This, of course, is going to be the treatment of choice for most skin cancers: surgical excision. You should also be aware that there's a form of skin surgery referred to as Mohs, micrographic surgery. This is a technique in which the lesion is removed and it's looked at right there. The histology is reviewed, and then it's mapped out as to where the extension, what part of the cancer is going to which border. And you keep excising in the direction of where you see the cancer to the border. And this allows you to cut out the total cancer with maximum preservation of the tissue surrounding it that's not involved. Okay, let's talk a little bit about melanomas. Mentioning here some of the risk factors of developing melanoma. Certainly fair-skinned individuals. By type 1 and type 2 skin, we're talking about the people that as soon as they get out in the sunlight, they burn and they never tan. That's one. And the type 2 skin is the individual that burns, gets a few freckles, and thinks that by going out any number of times after that, the freckles will unite and they'll have a tan. Let me tell you, this is not going to happen. Don't even try it. So, excessive sun exposure, immunosuppression I already mentioned for the non-melanoma skin cancers. It's also true for melanomas. If somebody has a family history of melanoma, they're at risk of developing melanoma. Certainly if they've had one melanoma, they're at risk for developing additional melanomas. If they have some abnormal or funny looking or dysplastic or atypical moles, then they are at increased risk. And if you have an increased number of just regular nevi, which tend to be related to excessive sun exposure, you're at higher risk. And there are some precursor lesions, congenital nevi, and a thing called lentigo maligna. So, red or blonde hair, this is just a fair-skinned individual. Actinic keratosis, this just is also a marker for someone that has fair skin, excessive sun exposure. Marked freckling of the back, again, a marker of excessive sun exposure. We already mentioned the history of melanoma. People that used to go out in the sun and got repeated sunburns because they wanted to try to tan are at high risk. And this just reflects that, the excessive sun exposure when you've had outdoor jobs or as a teenager. This is a list of some of the melanoma precursors: lentigo maligna, dysplastic nevi, congenital nevi, and acquired nevi. This is an example of lentigo maligna. What you're looking at is a large patch, sometimes referred to as a large macule. You can use, some people use patch as a large macule, other people just descriptively say macule and then they say large macule. Anyway, what I'm trying to say is this is a flat lesion, you cannot palpate it, and you're looking at a large area of brown discoloration, various shades of brown. Many of you are used to seeing a fairly uniform light brown color like this and recognizing that as what we call a solar lentigo. Some people call it liver spots. Very common on fair-skinned individuals, face and the back of the hands. Here we're talking about a lesion that's much larger than the typical lentigo and also has this irregular pigmentation within it. So this is a lesion that needs to be recognized. It's always going to be in sun-exposed skin, and it's always going to be on fair-skinned individuals. Another example of the same thing. Here we have a person, a lady that has numerous freckles. So you know that the sun exposure over the years has been way too much, and she's developed this multicolored, large brown patch. And this is a lentigo maligna. This is just to point out on this lady's face you have that same background patch, but indeed right there in the middle she has developed a nodule, and now we're using the term lentigo maligna melanoma. This individual has a congenital nevus. This has been there since birth, but he has developed a nodule within his congenital nevus. It doesn't happen so often. The risk is probably about 1 or 2% over a lifetime, that when you have a small congenital nevus, for it to develop a melanoma. This is an example of what we're referring to when we talk about atypical moles or dysplastic nevi. These are nevi that have variation in size and shape. You have a group of nevi like this where one does not resemble the other one. Some of them are small, some of them are larger. For practical purposes, most of them are greater than 5 millimeters, somewhere between 5 and 10 millimeters in size, whereas your typical nevus that's not congenital is normally about 5 millimeters or less in size. So what I'm saying to you is a global view of this slide showing multiple irregular type nevi, not the classic round or oval 5 millimeter nevus you're used to looking at. A close-up of some of these lesions just to show you the variation in sizes and shapes, all looking a little bit different. And here's an example of one where you have a kind of a reddish brown peripheral area and some darker brown and a little bit raised in the center. Now, when you're looking at this, you might say, well, how come that's not a melanoma? It actually might be, but more practically, this is going to be a dysplastic nevus. What does all this mean? Why am I even talking about dysplastic nevi? Dysplastic nevi represent a sign that says to you that this patient is at risk of developing melanoma. If the family history is such that one member has had a melanoma, first-degree relative, the patient's risk is 50% over a lifetime of developing a melanoma themselves. If they have 2 first-degree relatives, the chance of them developing a melanoma is almost 100%. So a person with many dysplastic nevi, they have the dysplastic nevus syndrome, they're at major risk of developing melanoma over their lifetime. The majority of the nevi will not develop into melanoma. The melanoma will develop de novo, separate from the skin lesion. However, some of the skin lesions can develop into melanoma. So what it means to you is that be able to recognize that this individual is at high risk of developing melanoma and keep close tabs on them and follow them either personally or else send them to a specialist to monitor. So again, back in the last millennium in 1999, some of the statistics New cases of melanoma in the United States, 44,200. The current guess for the year 2000 is an estimated 47,700. Again, I think my own personal bias is that this is a rough estimate and it's probably higher than that. The lifetime risk was estimated to be 1 in 79. It's now estimated in the year 2000 to be 1 in 75. What does that translate to? If you have a child that's born in the United States today, you would expect that in their lifetime they have a 1 in 75 risk of developing a melanoma. The expected deaths are estimated this year to be 7,700, and the proportion is probably 2 men for every woman. And in the VA system, you're certainly concerned about this statistic because the bottom portion where it says highest mortality rate is in older Caucasian men. That's what we're talking about when we're talking about the VA population. These patients are at major risk of developing melanoma. It's a rare month that goes by without us seeing at least 2 or 3 melanomas in our VA clinic, seeing patients twice a week. The types of melanomas are well written up in the books. There's a superficial spreading type, which is the majority, around 70%. There's a nodular form where there's no spreading component, somewhere around 20 to 25%. There's a small percentage of the lentigo-malignant type that I showed you on the cheeks of older fair-skinned individuals. And then there's a form that occurs on the extremities. It's called acrolentiginous melanoma, and the people that are at risk for this one tend to be the darker-skinned individuals, including African Americans. So, some typical examples of melanoma. We have a small flat papule, fairly uniform in color, a little bit abnormal in shape. It's a little bit hard to tell. This could be a nevus, it could be an early melanoma, it could be a melanoma in situ, but certainly the dark color against the fair-skinned background makes you want to biopsy this. This is an early melanoma. Here we see on the upper lateral lip several areas of discoloration. The lesion's about 1 centimeter in size, irregular shape, little nodular component, dark brown, and light reddish brown discoloration. A classical example of a melanoma on the chest. This is a 2 centimeter lesion. It has a pink area, it has a reddish brown area, and it has a dark brown area with a nodule here. This is the classic prototypic type of superficial spreading melanoma. On the leg of an individual, let me back up and say that many of the melanomas on women are going to be on the legs, and on men are going to be on the back. Here we have a lady with melanoma, irregular pigmentation on the edge and a nodule in the center. You can see on this close-up photo the irregular pigmentation and the nodule in the center. On the lower leg of a woman, fair-skinned individual, this is the shoe here, the foot. And so you have this irregular pigmentation and the nodule in the center. I don't think many of you would miss this as a melanoma. Back to the classic presentation with all the discoloration, the so-called ABCDs, the asymmetry representing A, the irregular borders, the variation in colors, and the large size. Usually it's going to be 6 millimeters or more in diameter. For comparison, this is a 5 millimeter seborrheic keratosis. Again, a nodule within a large area. Here you have an area of regression, this white area. On the plantar surface of the foot, this is the great toe. Here you have what looks like a lentigo maligna, only it's not in sun-damaged skin. This is the acrolentiginous melanoma. Same kind of dark discoloration with a nodule on the side of the foot. And here we have a melanoma involving the nail bed. It's something that has to be considered every time you see some pigmentation in the nail or in the nail bed. You have to worry about an acral lentiginous melanoma. Another example of the same thing with pigment coming onto the proximal nail fold. This is so-called Hutchinson sign, where if you see pigmentation coming from the nail bed onto the proximal nail fold, this is very significant. Certainly nobody would miss a large nodular melanoma on the earlobe, a little bit unusual location. Another example of a large nodular melanoma in the genital area of a woman. One of the things that you have to realize is that patients tend to be a little bit reluctant in showing you certain areas of their body, and it's very difficult to make a diagnosis if you don't see the lesion. We encourage total body skin exams. I know that sometimes we get some strange looks when we're asked if we could take a look at the total body when only certain concerns are involved. But this is the type of thing we certainly want to be able to avoid. If you miss the diagnosis of melanoma and it gets out of control, this is what metastatic melanoma to the skin can look like. The patient died a day after this slide was taken. This slide shows you the determination of prognosis in anybody with melanoma. It's based on the depth of the lesion for the most part. It's called Breslow's depth, and it goes from the granular layer of the epidermis down to the deepest melanoma cell. And that measurement by the pathologist is what gives you information about the prognosis for this patient. If the lesion is 1 millimeter or less, it's a very good prognosis. If it's more than 1 millimeter, the prognosis starts to go down. If it's greater than 4 millimeters, it's really abysmal. Okay, depth of invasion, Breslow's depth. Ulceration, of course, you could imagine that if a melanoma ulcerates, that would be an important consideration. If you actually see white areas of regression, that's also a bad prognostic sign. Clark's level, which was used for many years before Breslow described Breslow's depth, is where the melanoma, how far the melanoma has gotten into the skin. So if it's in the epidermis, it's Clark's level 1. If it's just in the papillary dermis, it's 2. Papillary and reticular dermis, level 3. It's in the reticular dermis, level 4. If it's actually involving the fat, it's level 5. Breslow's depth and some information about Clark's level is also very helpful. This thing about radial versus vertical growth phase. If the melanoma is growing on the surface and spreading out, that's what we mean by radial growth phase. And that's still curable. When the melanoma has gone deep into the skin, its vertical growth phase, that's when melanoma becomes very difficult to treat. Patient gender, females have a better prognosis than males do. I showed you a slide where the elderly male has the highest risk of dying from the melanoma. Okay, if you have somebody with a melanoma that's 1 millimeter or less, these are some of the recommendations. You ask about a family history of melanoma. You ask about a personal history of melanoma. You do a total body skin exam. You palpate the nodes. You do a surgical excision. If it's a melanoma in situ, then you do a 5 millimeter border around the melanoma, and that's a surgical excision, and that's essentially almost a cured lesion. The 1 centimeter margin would apply to anything beyond melanoma in situ. So if the diagnosis is clear melanoma, and it's 1 millimeter or less in depth, then the treatment of choice would be 1 centimeter margin excision. If you have a 2 millimeter depth, you get 2 centimeter border. If you have a 3 centimeter depth and you can get around it, you do a 3 centimeter border, and after that you quit. There's no more of the old 5 centimeter borders with the huge deep scars and grafts. Diagnostic studies are really not indicated. Chest x-ray is controversial. This is what we're talking about now is an early melanoma. We're not talking about the ones that are 2, 3, 4, and 5 millimeters in depth. Okay, my final slide says, can you believe this maniac? No sunscreen. And this guy is jumping off a cliff. I like to use this slide to express my opinions about sun protection. First of all, I want to say that sunscreens are only a part of the overall program of sun protection. We do not want to imply that if you put a sunscreen on, it's okay for you to go out, have your tank top, shorts, sandals, go down to Corpus Christi, go out on the boat, and fish in the middle of the day. If you're going to do all those activities, which is fine, you want to have a broad, a wide brim hat. We recommend a 4 centimeter brim on the hat. You want to make sure that the hat has no holes in it. For my colleague in ophthalmology and for my colleagues in ophthalmology and optometry, I always recommend that the glasses or the contact lenses be protected from ultraviolet light, that they have a coating for the whole range of UVB and UVA. I recommend long sleeves, long pants, and sunscreens, face and hands. Now, I realize that many of you will say it's too hot. There's always excuses. Well, it's hot in the Middle East, and people manage to cover up very nicely to where only their eyes are showing. So I really don't buy the concept that you can't cover up. Yes, you can. The alternative is to come and see me and help me pay for my daughter's college tuition. So in summary, I hope I have shown you some representative examples of the most common skin cancers: basal cell carcinoma, squamous cell carcinoma, and melanoma. I've shown you some of the precursor lesions for each of these that have precursor lesions, and I hope I've emphasized to you the importance of certain types of skin cancer, certain locations that must be dealt with and must be dealt with promptly. At this point in time, I'm going to go ahead and stop and entertain any questions.
I guess it's obvious that the 1-2 centimeters border is after you take the initial biopsy.
The question is the border that you take after you biopsy the lesion, is that are you now taking a border beyond your initial biopsy? So, in other words, you excised the primary lesion, you made the diagnosis, and now you're trying to decide what border you take. That's correct. So now the patient comes back to you, they have a nice line scar from your surgery, you're taking a centimeter border beyond that scar. Now, what I did not mention is what's now currently happening in melanoma, in that there's lots of talk about sentinel nodes, trying to determine whether the melanoma has spread beyond the skin. And so there is such a thing called the sentinel node biopsy. And in specialized centers, a dye is injected into the skin around the lesion, and it's traced out. It's a radioactive dye, and it's traced out to where that dye, to which lymph node chain it went to. And you take that first node in that chain and you step section through it looking for melanoma. And if you find melanoma there, then obviously the prognosis is going to be worse than if you did not find it there. And we are very fortunate to have a physician at the Cancer Therapy Research Center. Dr. Alexander Miller is an oncologist who does a surgical oncologist that does his major work with melanoma, and he is very interested in doing sentinel node biopsies and trying to give a better prognosis for melanoma patients. So I highly encourage you to use his services. Any other questions? The question, first of all, there's no such thing as a stupid question. They're all good questions. And the question was whether it matters what part of the day you're exposed as far as developing skin cancer. I didn't cover this, but let me briefly say that it's clear that squamous cell carcinomas, actinic keratoses, are related to ultraviolet B light. That's the wavelength from 290 to 320, and all sunscreens cover that wavelength very well. What is not so certain is what the wavelength is for basal cell carcinomas. It's probably the same UVB, but there are other factors for basal cells. And what's not known is what the wavelength is for melanoma. We clearly know that ultraviolet light plays a major role in melanomas. We cannot tell you what the wavelength is. So having said all of that, as a background for your question, we know that the highest level of ultraviolet B will be in that time frame from 10 to 4 in the afternoon, with 12 to 1 being the worst time. So what that means is what you should be doing is, if you can, do your activities in the morning before 10 or after 4 in the afternoon to cut down on your risk of too much sun. The UVA tends to be fairly high throughout the entire day. So even at 5 in the afternoon, you can have significant amount of UVA exposure. So if indeed it turns out that melanoma is significantly involved with that wavelength, then that exposure would be important too. Any other questions? I thank you for your attendance.